Hello, my name is Jay Patel and I'm a VCU fellow in cardiothoracic surgery, and here I have Dr. Mohammed Qadir, cardiac surgeon at VCU.
Hello.
And today we'll be talking about pitfalls and guidelines for ACT. So Dr. Qadir, what is ACT?
So ACT is an activated clotting time. It is a substitute for a partial thromboprostin time, which takes much longer time to measure. So this is a point of test care in the operating room where you can immediately get the level of anticoagulation measurement with ACT.
Okay, excellent. And Dr. Qadir, how do you interpret ACT values? What sort of targets are you trying to get with your ACT depending on the different surgeries that you do?
So we use the ACT to measure the effectiveness of heparin as an anticoagulant. That's the principle that we use this metric for. And normal number is 70 to 120 seconds. A therapeutic ACT to run heart-lung machine safely is over 400 seconds. And the way that we do this ACT test is we add the intrinsic clotting factors to a blood sample and we let it sit down and we look for formation of clot, either by optical measurement, which is the most common way of doing it, or by just visual inspection to see that the blood has become thick and has clotted. So whatever the number of time that it takes in seconds is your ACT.
Okay. And Dr. Qadir, usually how much heparin do you have to give to achieve certain ACTs? And if your ACT is not within that range of more than 400, how do you determine the additional doses to give?
So normal dosage is between 300 to 500 units of heparin per kilogram of body weight for the patient. And the ACT we target to achieve is over 400. If it is still less than 400, the first thing that we do is we increase the dose from between 500 to 800 units per kg body weight. And that's the max that we go before we say that dose of the heparin is ineffective in attaining therapeutic anticoagulation. And then you start thinking about what else can you do.
Okay. What are some variables, patient-related variables, operative variables that can potentially affect your ACT values?
So the big patient-related variables are if they have any clotting factor deficiencies, and more importantly, if they have been on systemic anticoagulation pre-surgery, where antithrombin 3, which is essential to form the blood clot and be effective through use of heparin, is going to be depleted. So clotting factor depletion from the patient end is the most common one. The machine-related factors are from hemodilution. So if the blood has become too dilute on the heart-lung machine, then the amount of the clotting factor levels are also going to be less. So that also affects your ACT number. And some drugs, in particular, if the person has already been on heparin from before, or if the patients have unusually high amount of the platelets, where the platelet factor 4 can adversely affect the workings of the heparin.
Okay, excellent. And lastly, Dr. Qadir, whenever you are in a scenario in which you're concerned about heparin resistance, what are the steps that you take to manage that?
Perfect. So one thing that you have to keep it in mind, that what are the most common things? Antithrombin 3 low levels, either from patient being on the heparin for too long from prior to surgery, is the most common reason. So the second one being decreased amount of the clotting factors, and that could come from the liver disease of the patient or hemodilution. So the thing that we do first after going up on the dose of the heparin up to 800 units per kg body weight is by supplying the antithrombin 3. The two most common ways of supplying are giving fresh frozen plasma. So if you give 2 units of fresh frozen plasma, that equals to approximately 500 international units of antithrombin 3. Or you could directly provide antithrombin 3, which is the recombinant dose that's available.
Got it. Okay. Well, thank you for that, Dr. Qadir.
Absolutely.